Today we're going to cover the respiratory changes that occur in morbid obesity. Let's start off by defining obesity, which occurs when the BMI is greater than 30. Morbid obesity occurs when the BMI is greater than 35. We should also think about some preconditions that make obesity unique in its effects on the respiratory physiology. Firstly, there is increased fat around the respiratory system. This includes fat deposited around the airway, chest and abdomen. Next, there is increased muscle mass in obesity, which results in increased oxygen consumption and carbon dioxide production. In terms of anatomy, there is increased fatty infiltration of the upper airway, which makes the airway prone to obstruction. Consequently, there is increased risk of obstructive sleep apnea, intubation difficulty, and difficulty with bag mask ventilation. For control of breathing, there are some unique changes that occur in obesity. First off, as previously mentioned, obese patients are prone to obstructive sleep apnea. This results in hypoventilation and a fall in oxygen and a rise in carbon dioxide. This causes a rise in pulmonary vascular resistance and right ventricular afterload, as well as polycythemia. Secondly, they are also prone to develop obesity hyperventilation syndrome, which occurs as a compensatory mechanism to increased worker breathing. Initially, there is increased carbon dioxide due to increased production and an inability to efficiently clear the CO2 due to poor respiratory mechanics. And we'll get into this in more detail later in the video. Normally, this would cause markedly increased minute ventilation to eliminate the carbon dioxide. However, chronic CO2 elevations cause a decreased sensitivity of central chemoreceptors to carbon dioxide. This is a compensatory mechanism to minimize energy wasted on respiratory muscles trying to correct the CO2 elevation, as well as to minimize respiratory fatigue. Finally, compared to the non-obese patient, the increased muscle and fat tissue results in increased oxygen consumption and increased CO2 production, which ultimately causes increased respiratory rate at rest. In terms of pressure changes, the main change is that there's increased intrapleural pressure, which is due to increased weight on the thoracic wall and increased intra-abdominal pressure. The pressure changes affect volume such that there is a decrease in functional residual capacity due to the rise in intrapleural pressure. And the rise in intra-abdominal pressure causes the diaphragm to be pushed cranially. A fall in functional residual capacity means that it can fall below the closing capacity. This causes increased atelectasis due to increased small airway closure at expiration. There's also increased VQ scatter and shunt, which increases the venous admixture, ultimately resulting in hypoxemia. Overall, a fall in functional residual capacity and the closing capacity being greater than functional residual capacity will cause decreased oxygen stores and predispose to hypoxemia. Moving on to compliance, there is decreased chest wall compliance due to the increased thoracic and abdominal fat. There is decreased lung compliance due to 1. Reduced lung volumes and basal atelectasis, which will contribute to worse static compliance. And secondly, there's increased airway resistance from small airway closure and increased respiratory rate, which will contribute to worse dynamic compliance. Now, if we plot a pressure volume graph with pressure on the x-axis and volume on the y-axis, we can see the shape of the curve for a non-obese patient in orange. When we plot the curve for obese patients, it is shifted to the right, which represents the overall reduced respiratory system compliance. Next, we'll talk about airway resistance. This is also increased in obesity due to decreased lung volumes, which cause less radial traction on small airways. Combining what we have covered so far, we'll now look at work of breathing. There is increased work of breathing due to 1. An increased pressure required to achieve the same tidal volume due to decreased respiratory compliance. 2, there's increased airway resistance, which will require increased pressure to overcome this resistance. 3, there's increased respiratory rate, which will cause increased gas flow, which also causes increased resistance. The consequence of increased worker breathing is that it will cause increased oxygen consumption of the respiratory muscles, which means that there is a decreased respiratory muscle efficiency. Again, we'll combine what we've covered so far to examine VQ mismatch. There is increased VQ scatter due to a reduced lung volumes, atelectasis, and that the closing capacity is greater than functional residual capacity. Importantly, VQ mismatch worsens when the obese patient is supine, since more abdominal weight pushes the diaphragm further cranially, which worsens the already reduced lung volumes and atelectasis. As a side note, this is why the safe apnea time for obese patients in the supine position is dramatically reduced. Looking at the changes to pulmonary circulation, there is increased pulmonary vascular resistance due to the hypoxic pulmonary vasoconstriction, hypercapnia, as well as low lung volumes, which tends to compress extra-alveolar capillaries. Chronically, this causes pulmonary hypertension and right heart failure. In terms of gas exchange, hypoxemia occurs due to the previously mentioned VQ mismatch and atelectasis. Hypercapnia occurs due to the poor respiratory mechanics, which are unable to efficiently increase minute ventilation to eliminate carbon dioxide. Additionally, obesity hyperventilation syndrome decreases central sensitivity to carbon dioxide, permitting this rise in carbon dioxide. Finally, we'll look at acid-base status. There is often a chronic respiratory acidosis due to obesity hyperventilation syndrome. Okay, let's recap what we've just learned. In obesity, there is increased fat around the respiratory system, and there is increased muscle mass, which causes higher oxygen consumption and CO2 production. The anatomy is prone to obstruction, with higher risk of obstructive sleep apnea. The control of breathing is altered, and a higher risk of obstructive sleep apnea and obesity hyperventilation syndrome, which is characterized by a decreased central CO2 sensitivity. There is high intrapleural pressure, which causes the fall in functional residual capacity. The functional residual capacity tends to fall below closing capacity, and this contributes to hypoxemia. Both static and dynamic compliance are reduced, and there is a decrease in respiratory compliance, which can be seen as a right shift on the pressure volume loop. There's increased resistance due to less radial traction on airways. There is increased worker breathing due to several factors, such as poor compliance, airway resistance, and increased respiratory rate. This causes an increased oxygen demand and reduces respiratory muscle efficiency. There is increased VQ mismatch, which contributes to the reduced arterial partial pressure of oxygen. There is increased pulmonary vascular resistance due to increased hypoxic pulmonary vascular resistance, increased carbon dioxide, and reduced lung volumes. Over the long term, this causes pulmonary hypertension and right heart failure. Finally, there is hypoxemia, hypercapnia, and a chronic respiratory acidosis. Alright, that's the end of the video. Thanks for watching, guys. Make sure to subscribe if you're new to the channel, and please like the video if it's helped you out. Please comment below for any questions you have or topics you want me to cover in the future. And just remember, every day you are learning more and more.